afternoon from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have the honor of broadcasting the Pediatric Neurosurgery webinar series of cons, and we'll let Llewellyn Padayaki take over. It's all yours, Llewellyn.
Thanks, John. Again, we'd have to start off by just thanking you for all the effort you put in coordinating this and disseminating the word. And then I want to welcome our panelists and speakers this morning. We have a host of really esteemed international speakers. Firstly, I'd like to welcome Moody Qureshi from Cannes, who's always been supportive of this initiative right from the beginning, Moody. So thanks again. I can't thank you enough for all your support. And Bello, I think, hasn't quite joined us yet, but Bello Sher, who's going to take over from Moody, or has already Moody, I'm not quite sure.
No, he hasn't. He was reluctant. He wants the whole team to be on board, you know, the secretary, treasurer. So we're hoping that in Bogota we'll kind of, otherwise I'll become the Robert Mugabe of Africa, you know. Yeah, so Bello's hanging in there.
Yeah, okay. Thanks, Moody. Sounds like a very African thing there. And then my co-host, Mohammed El Beltagi. We've been running this together for a while now, Mo. I think persistence is our strongest attribute. Eh? And then I'd like to welcome our really esteemed speakers. We're really honored to have two world-class speakers in Adrian Caceres, who's a pediatric neurosurgeon from Costa Rica, and Chandrasekhar Deopujari, who's, in my opinion, easily one of India's leading neurosurgeons and a real light in an icon in pediatric neurosurgery worldwide. So out of respect for their accomplishments, we introduce them individually before their talks. Mo, you want to start off? We'll start off with Adrian Caceres. So I'll hand over to Mohammed El-Beltagi to introduce Adrian.
Thank you, Llewellyn, and thanks, John, for hosting. Thanks, Moody. And start with Dr. Adrian Caceres' speech. Dr. Caceres is a clinical professor at the Department of Neurological Surgery at the University of Costa Rica and is director of the Brain Tumor Clinic at the National Children's Hospital of Costa Rica. He is used to be the chair of the communication committee at the ISPN and now the treasurer of the ISPN. Dr. Caceres has many international publications and presentations with many chapter books in the pediatric neurosurgery. We're looking forward to your talk, Adrian. Please share your screen.
So while I'm sharing my screen, I would like to thank the CANS committee for inviting me to share this interesting topic that hopefully will give you some perspective at the issues that are involved in ICP monitoring. So let me just accommodate my slide here. So today we're going to talk about whether there is actually a role for ICP monitoring in pediatric head injury. Okay, let's see. So just a simple disclosure that I'm a consultant for Medtronic, but not associated directly with ICP monitoring. So, okay, so jumping into ICP monitoring, as you know, every a few handful of years, the Brain Trauma Foundation gathers the experience of publications worldwide and tries to come up with recommendations for all of the things that are trauma related. Now, it has been interesting that we have gone now into the third version of these guidelines, so almost more than 20 plus years of experience. And still, at this point, the certainty for recommendation for ICP monitoring is roughly class 3. So, just to underline that, what that means is that the evidence out there is anecdotic. And there is some evidence that suggests that ICP monitoring can actually improve the overall outcome in traumatic brain injury, but it's not very clear, and we're going to see why we have failed to gather more information in this realm. So I think it's very important to consider that a PICU is not an adult ICU. A PICU is a very unique environment. Our pediatric patients are not unlike the adult patients, and their requirements for management are significantly different. So whenever you see a patient that 90 plus of the machines are bigger than the patient, then you know it's picky and you know it's bad. So this is one of our usual environments. So what do we know? We know that yes, as a result of primary brain injury, you can either get at the very same site of where the trauma happened, the development of hematomas, concussions, or diffuse axonal injury. And then as time goes by, we'll get secondary injury that can be mediated, you know, in this graph, either by an increase in the intracranial pressure and also by ischemia. And these ischemia is produced by secondary insults. Now, whether ICP goes on to produce ischemia or whether ischemia goes on to produce increased ICP, well, that's part of the discussion. And we know that will lead to receptor-mediated damage, inflammation, oxidative damage, and most importantly, the outflux of calcium. It's probably the double tap that will injure the membranes of the neuron. As you know, once calcium is deployed, there is an irreversible cascade which will liquidate the double layer of the cellular membrane. And now we have gathered a lot of information about what goes on with the patients and how we can actually intend to minimize some of these injuries. Of course, you know, cell action stretching, diffuse axonal injury, the breakdown of the barrier, synapse loss or hemorrhage are things that cannot be changed because they already happened. But then as time goes by, we have all these cascades of things that we have learned in the following hours and can actually make a big change in the outcome for these patients. We're beginning to understand that there's a late genomic response. There's neuroendocrine responses that can also modulate how the neuron is going to end up and how these will reflect on a neurological behavioral sequelae on the long term. So very exciting, all the things that we have come to learn. But then again, what happens with the trauma patients? As years have progressed, we have come to realize that there are several simultaneous factors that are confounding. You know, pre-hospital care has gotten so much better. Now, it is not rare that some of these patients are intubated at the site of the injury, that they're protected, their airway is protected, they're resuscitated with fluids. So there's early airway management. Some of these patients who are having bleeding, they're aggressively treated. Some centers do practice osmolar therapies. And of course, it has gotten better and better. So now we have more rapid access to CT imaging. And of course, you know, we have also improved in several other realms as enteral nutrition and some other requirements of the trauma patients. So I guess if you ask any neurosurgeon, everybody will tell you that yes, sustained elevation of ICP represents this key pathophysiological variable. And this will determine the outcome of a patient. If the ICP is raised, the likeliness of having a bad outcome, it's going to be very evident. You know, A plus B equals C. And of course, you might say that if there's a patient that comes in with this CAT scan and is having a GCS of 5, this is where the things get a little bit blurry because some clinicians might say that, yes, we should go ahead, put an ICP monitor and treat aggressively this child. While some others would say, well, the thing is, the patient came intubated, is sedated and paralyzed, and all I have now is a GCS of 3 His pupils are myotic, probably related to medication. So how could I know whether this is a salvageable patient? Should I insert an ICP, or is this patient completely doomed to die because of the injuries he has already sustained? So this is where things get a little bit tricky. More and more, we are getting patients that come into our emergency departments who are intubated, who are paralyzed and heavily sedated, and therefore we have very little clinical exam, and then we have to rely on images. Some of others might say that, oh, this is a patient who already sustained a hypoxic injury, and the likeliness of rescuing this patient to a significant neurological outcome is going to be very poor. So some people might choose not to insert an ICP monitor and just treat him as things go along. So it's important to say that there's this variation in therapy and outcome for pediatric head trauma patients. It was looked at Tilford. And what they study, they determined that ICP monitoring and targeted intervention to lower the ICP, of course, had better outcomes. And ICP monitoring and craniotomy led to better outcomes. But some other analysis came out to show that systemic hypotension, as we know from the data from the traumatic coma data bank, and hypoxemia are the main drivers for bad outcome. And of course, intracranial hypertension and systemic hypertension after traumatic brain injury are quite significant. But like I said before, it's really unclear whether it's primary intracranial hypertension or reduced cerebral perfusion what will cause secondary injury. And the role of ICP monitoring as a mean of evaluating and manipulating CPP, it's also unclear. So what are the problems with studies regarding ICP and outcomes? Excuse me for
Yeah, I think Dr.
my apologies. So the problems with studies regarding ICP and outcomes can be related to small sample sizes, inadequate severity along or descriptions of severity along the different cohorts. And sometimes when you try to go back, there are different database codes. I think this is something that's going to improve as current technology is undergoing what we know now as data lakes. This is a capability of modern software to pull different databases, even though they're like reading out in different systems and codes, and it's able to perform analysis. Sometimes we just consider mortality as the only outcome to consider in regard to ICP. And sometimes patients are clustered by hospital. Okay. So this is an interesting paper published in Charles Nervous System, which has shown that less than 60% of patients with traumatic brain injury undergo ICP monitoring in the UK. And according to the Traumatic Coma Data Bank in the United States, 8 to 27% of children with severe head injury will undergo monitoring. And there's a study saying that in North Carolina, just 1/3 of the children lesser than 2 years old underwent ICP monitoring. So what are the reasons? Well, like I said, sometimes there's a patient that's described as coming in with a low GCS score, and upon arrival, you scan the child, he doesn't look that bad, and the child is moving all fours, and therefore you consider that perhaps this is not an originally labeled high or severe head injury patient, and then you want to wait. some of the patients, when they come in, they're actually moribund, and then you consider not to place an ICP monitor. So what are some of the alleged reasons for not placing the ICP monitor? Well, like I said, inappropriate initial classification. Some patients do come in a postictal state. This is something that happens very frequently. A patient had a seizure, is unresponsive, he gets intubated, he fell upon having the seizure, and therefore he is having a very different GCS score from what his clinical status is. Some patients do come in intoxicated, and it's very hard to know what is the actual GCS score. Some patients have a very bad initial GCS, but whenever you scan them, they have a very innocent neuroimaging. Or on the contrary, they have devastating neuroimaging. And of course, like everything in medicine, some surgeons would just give out their opinion and think, I think this is a patient that doesn't look that bad, let's wait. Right? And of course, there's a lot of opinions regarding on how to correctly interpret images from infants and toddlers. And also, as you look at the databases, there's a lot of patients who never got an ICP monitor, and it's not documented the reason, so very hard to analyze. Some patients come in with an epidural hematoma, and even though their GCS score, because they suffered a vehicle injury, the initial GCS score is low, but you look at this and you say, okay, this is an epidural hematoma. I know that it's pretty likely that once I drain it, the patient's going to do well, so you decide not to place a monitor. The other subgroup of patients are those who have laminar hematomas, which you would very likely think twice before putting in an ICP monitor. And then you have the patients who look like this, patients who have an acute subdural, they have herniation, closed cisterns, diffuse subarachnoid hemorrhage, in whom you might not expect this patient to recover adequately if he's coming in with GCS3 and bilateral dilated pupils. And of course, this is in a scenario that can change widely in between centers. I do practice in a third world country where money it's not given out freely, and we're really responsible of how to handle our budget. So perhaps in some centers in the United States, you will put in an ICP monitor because you want to give the patient every single choice that he's got, even though he might not make it, but you're covered legally because you did everything that you could on at hand. But it's very likely that in some of the countries where you have to choose who should receive that ICP fiber, which is not cheap, then you have to choose more wisely. So some of these things affect these outcomes. The other thing that affects the impact of ICP monitoring is that, of course, there's no way to run a prospective, double-blinded, randomized trial on trauma. Everything is mostly retrospective. Sometimes you can randomize, but even then, the data and the consistency are either low or moderate. So no absolute data when you use ICP monitoring with patients as unit of measure, as you can see here, or hospitals as units of measure. So I think the main question is, are children with severe traumatic brain injury at risk of intracranial hypertension? How can we know? So diffuse cerebral swelling on a CAT scan is 75% specific for the presence of intracranial hypertension. So sometimes, and I guess many of you have been in that scenario where you were completely sure that he was going to have a raised ICP, you put in the monitor and it's very decent. But we also know that almost 1/3 of the children who had an initial ICP measurement greater than 20 millimeters will have an additional raise of their ICP during their intensive care course. And We also know that intracranial hypertension might be significantly worse in children who do not have spontaneous motor responses than in those who do. And the problem is that we don't have any alternative. As much as we would like to, there's not a reliable non-invasive method to detect intracranial hypertension. And this is even worse when we get to toddlers and infants who have open fontanelles. Okay. So are ICP data useful in the management of these patients? So there were 15 studies involving almost 900 patients who demonstrated an association between raised ICP and poor neurological outcome or death. So the thing is that monitoring and treatment, will it improve the outcome? And this is a study that was published recently, again, reviewing the data from the National Trauma Data Bank. And look at the things that we can see here, that when you compare ICP monitoring with no ICP monitoring, really you can tell that the difference were not that significant. And especially when you look at ICP versus non-ICP, you'll see that patients who had ICP monitoring had a greater length of stay in the ICU. They had a greater length of stay at the hospital, and the charges were significantly greater because of the technology that was involved. Now, the tricky question is, how many of these patients are not considered within the length of stay of the ICU or the hospital because they died, because they didn't require ICP monitoring because they were, just too sick, or patients who initially did too well and therefore actually went out of the ICU faster. So this is where the data become tricky. So what we know from this study that was published in the Journal of the American Medical Association is that there's no significant difference in functional survival between the two groups. And there's no significant association between monitoring and hospital mortality. And we know that patients who are monitored, probably because of the fact that we're looking closer at the patient and we're doing more things for a patient who's severely injured, he might go on to survive. Some of these might die. Some of them will survive, but they're discharged to hospice. And it's very likely that because of the injuries, they will require a tracheostomy or a G tube. So we know that ICP monitor group had greater treatment intensity as opposed to the other group. Looking at the number is something that will move you to act. And probably some of you have used technology such as Lycox. Lycox is a technology that by sensing the tissue, the tissue oxygen saturation, you can get a lot of data that are really confounding if you're not used to this technology. So they're very treatment intense. So what's the functional outcome? Again, when you compare ICP versus no ICP, well, you can say that it's very likely that, yes, those who survived who had ICP had greater chances to have a G tube or a tracheostomy, and also patients who on this side of the chart, it's a busy slide, but the best way to look at it is that I think for many people it's really hard to undergo a smaller therapy without an ICP monitor and just like put it around the clock and see what happens. So the numbers are really confounding. You might say, I would never do that, but as you can see from the numbers, it's a practice that is not disregarded by many, and they will do hypertonic saline or mannitol in patients with no ICP monitoring. So that's very thought-provoking, or patients who actually even went into pentobarbital therapy, right, without any ICP monitoring. So when you look at this odds ratio, you know, when you look at the outcomes and then you try to bring it back into say, okay, so what happens with the outcomes and how that relates, whether does it favor having an ICP monitor or not? Incredibly enough, the results actually tend to tell us that probably patients who did not undergo ICP monitoring probably did better in some things. But of course, how you measure these outcomes, it's really tricky. So there's a study of 100 kids with severe head injury in which we actually looked at hyperventilation, diuretics, CSF drainage, sedation, paralysis, and barbiturates. And it was seen that, yes, children whose ICP was lowered actually had one better 1-year outcomes than those who did not, who had uncontrollable ICP. And the data that came out of this said that successful control of ICP, irrespective of treatment modality, seems to be important. It seems the data is inconclusive, but it shows us that perhaps that's the way to go. And in this study, also published last year in Child's Nervous System, says that roughly 85% of children who have an ICP monitor inserted will go on to receive therapy. So that leaves us with 15% who never required any therapy. This is actually a high number because Bailey reported that only 78% of the patients would go on to require. So this is also thought-provoking because you might say that there is a range in between, somewhere in between 15 and 20% of the patients where you actually saw that ICP was going to be like high, you inserted a monitor, and then you did nothing to treat that ICP because they did not require, and probably everything else that you were already doing was either doing the trick, right? From this study, they could find out that hypoxia prior to the NICU arrival, being a female and having a higher injury severity score actually related to a worse outcome. That's the injury severity score. So as you can see, it's not only the brain, but also the other areas of the body, which will add up to tell us how badly injured these patients are. So what are the recommendations based on all this discussion? Well, I think it's very important that once you put an ICP monitor, you need to understand the pathophysiology behind it. And it's just not a fancy tool that you put in and you watch it. It's something that will assist you to make decisions on targeted evidence-based care. And because there are no imaging or other biomarkers who can actually tell you when the patient is developing intracranial hypertension, well, we recommend that ICP is still measured to determine if intracranial hypertension is present. And because much of the present care is based on our recommendations to prevent and treat elevated ICP, I think as soon as you detect it, well, that will allow you to effectively treat it. And in doing so, perhaps you will prevent deterioration of the patient than in those who do not have an ICP monitor. Of course, many things are left in a patient who has an ICP monitor, like what's the best decision when to withdraw it if the patient is either getting better and upon awakening his ICP readings are getting increased, or the patient that no matter what you did, the ICP remains high, but the patient is actually somehow stable. I think that's also a scenario that many of you have encountered. Patients who are in between 20 and 30, the pupils are mid-sized, the patient is not either deteriorating or improving. And as days go by, then you start wondering whether you should just, keep on watching, or whether just having that ICP bolt will add up some infection to the patient, and then you have to come to these hard clinical decisions. So with those brief insights into ICP monitoring, I would like each and every one of you to have this thought-provoking discussion of how would you manage adequately your patients at each and every of your centers. So I thank you for the time.
Thank you, Adrian, for this nice presentation, as usual. And so, any comments? We move to Moody Qureshi. Do you have any comments on Adrian's presentation?
Thanks, Adrian. That's although you mentioned that you are in a low-income country, from where our perspective is that certainly, and I think Mohammed will agree, that certainly looks like a high-income country to us, and
Yes.
where we practice. But yeah, absolutely brilliant. You mentioned all the things that I mean, do you do Lycox monitoring in your units, Adrian?
Yes, Lycox came about 15 years ago. But
Okay.
one of the surprising things that as years have come by is that I have come to realize that in general,
Yeah.
I think the generation of our teachers, when we went back to medical school, we all are having gray hair now. But
Yeah,
what we were taught in the physiology class was a very simple way to accommodate some physics laws to what they thought mechanics would do within the brain. And I think when you talk about ICP, CSF, and a number of things, the traditional physics laws do not apply the way we think they do, right?
And possibly even more so in pediatrics than in adults.
Yes. And one of the surprising things is that you might, the theory says that if you hyperventilate a patient, you will bring down the ICP because of the effects it will have on the vessels, and because it will do this, it will do that. And then you have a patient you put on the Lycox, and you start hyperventilating to see whether that's going to improve, at least transiently, the ICP before you're putting in some smaller therapy. And you see that the oxygen even drops even further down. And then as the patient is actually getting better, his readings are not going the way you thought. So it's very labor intensive, and sometimes it's very confusing. So one of the things that happened, at least in our centers, is that initially, and I don't know whether, I think Llewellyn also had some experience while being at Cape Town.
Yeah.
ICU doctors hated it because it was so confounding to them. It was so labor intensive that they would rather stick to the old, prescribe fixed mannitol every 6 hours or put just a drip. And every single time the kid spikes, either open the EVD or, do whatever you have been doing for the last 50 years. So I think we're getting more and more data that that is providing us with a deeper knowledge of what's going on. Do you have any Lycox back at home?
No, we don't. The only unit on the continent, as far as I don't know whether Mohammed, you have them in Children's Hospital in Cairo.
No.
The only place we have them is in where Llewellyn worked with a group in UCT at the UCT, and I think that's, from my understanding, the only place. Llewellyn, you might want to enlighten us on what the score was when you were involved.
Yeah, so the score is a rolling target. So look, I mean, UCT and Tony and Graham's work when I was there, I was involved a little bit as well, is the most focused, productive research, and like Adrian says, and I've got to underscore that point. The only thing worse than no monitoring is bad monitoring. And bad monitoring is monitoring that can't be interpreted, appropriately or well enough by a neurointensivist or the emergency doctor or whoever it is. So in that context, it's probably best not to put a Lycox monitor in. Mohammed, you let me know what your thoughts are there. But I would have thought if you overwhelm people with information, that's kind of the worst thing you can do. So we do Lycox monitoring routinely in Pretoria, and I think there are a number of other centers in South Africa that use Lycox routinely. But the data collection and the processing and analysis, I think is still unique to Cape Town.
Yeah, I mean, Adrian, just thinking outside the box and pushing the paradigm to perhaps a different way of thinking. You know, the crucial thing about getting the Lycox, the ICP, the mannitol is essentially to provide a level of oxygen that to the cell. And one just wonders whether why we haven't ever thought about developing some sort of smaller unit that can provide, and it's a crazy thought, I agree, hyperbaric oxygen to that patient at a higher level. We're providing them at 100%, and the oxygen just isn't going because of the pressure and the perfusions. What are your thoughts on developing in the future hyperbaric oxygen therapy for some of these cases? I'm just throwing it out there.
Well, I think that's part of the puzzle. One of the things that was a real eye opener to me was, Live Cherian has history about draining the basal cisterns, and by improving the drainage of CSF, everything actually, in his experience, gets better, right? So we don't know whether it's hydraulics, what is this new lymphatic system that it's just messed up and it's not working adequately. But I think there are many lines of work out there that we need to pursue, and especially, you know, in our third world countries, uh, as Sandeep Chatterjee would say, you also come from a place with dusty roads. You know what it takes, to have a child who suffered an injury 8, 12 hours ago and now comes to your care, and now you have to make all these decisions. I think we're slowly getting there. Technology, at least having CT imaging, training surgeons to provide, basic care, is gradually getting there. But these really complex patients are really a challenge, and they're very taxing to any public health system, right? And especially, I think one of the most thought-provoking questions is that sometimes, at least we could say from our experience, patients who actually are discharged very, very disabled, at least in children, they come back 6 months later and say, "Hey, doctor, how are you?" Children do recover quite better than adults. This is not the case all the time for adults, right? But it has so many edges. Trauma care it's such an exciting scenario.
Yeah. Right, great, thank you.
Thank you, Adrian. Any comments from Chandra? Yeah.
No, actually, we do not use it on a regular basis, so not much in terms of personal experience. I am pretty sure that it has a place. The only question is we still do not know where and when. I think that's what I gather from Adrian's talk, even with recent references. So I think those two questions remain very important. I mean, can we really identify patients who should be monitored, and the yield of monitoring even in those patients, has it so that's where I'm still unsure as to what is the real place today of ICP monitoring in trauma. We use ICP monitoring many a times post-surgical, wherever there is a ventricle drain, they are used. But we do not have fiber so easily available. Now it has become available in India. And there are certain centers who are doing it, but most of this work is happening, as a research protocol. And that's where I actually want to ask. Levlin is quite passionate about it, or used to be. And I just want to know what is your experience in terms of clinical. I mean, even anecdotal cases might be okay if you tell us.
Yeah. No, thanks, Chandra. And I think a place like India and the burden of trauma that you guys experience certainly is a minefield of data. And like you quite correctly pointed out, and I think is a pervasive thought from all the speakers now. If you have the infrastructure, and at least it brings into question, do you have a dedicated neurointensivist who has the time to sit and analyze? Because ICP, I think like Adrian pointed out, at least can go up and Lycox can drop, and it can mean 5 different things. The patient could be having a seizure versus fever versus an expanding hematoma versus hydrocephalus, hyperemia, all these sorts of things. And if you don't have a dedicated person who interprets these things correctly, you can potentially cause more harm than good. Like was pointed out earlier, hyperventilation was thought to be the answer to all sorts of raised ICP problems, until we realized with multimodality monitoring that it actually is causing more harm. And while the number on one monitor heads in the right direction, that vasoconstriction and ischemia is detrimental. So I think if you have that infrastructure, and so what my practice here in Pretoria now is that ICP and Lycox monitors, again, we fit all those indications, but unless that can be placed in our ICU, we don't place them. And if it's after 48 or 72 hours, which does often happen, we don't place them, because the one thing I'll just my kind of one thought that pervades here is, if you place these monitors and you provide readings for people who have nothing or no way of interpreting them, then that's a recipe for causing more harm.
The other thing that can happen, Llewellyn, is that once you develop, at least in my center, this tradition that you come in the middle of the night and you put an ICP monitor for a child who has head injury and had some edema, then you start getting calls because there's a child who has hepatic failure and has some brain edema. Now they want to monitor too. And now there's a child who had an acute gastroenteritis and has some brain edema. They want to monitor too. And incredibly enough, and this has been my experience, some of these patients in which you look at the CAT scan, you would swear that the ICP is high, you put a monitor, ICP is normal. And then on the other hand, there are some patients that you would swear on the book that the ICP is going to be normal and the ICP is high, right? So it's very confounding to me sometimes. But we do get a lot of, every now and then, all these requests to put ICP monitor in stuff that it's not traumatic, and that I'm not sure whether that really assists, or it's just a number for the ICU physicians to be watching that, just to say, oh yeah, the patient is really in bad shape.
So just I'll add one more comment there, maybe just for opinions really, and to touch on the point you made now, Adrian. And in your talk you mentioned, so non-invasive ICP monitoring, something I've spent quite a bit of time with now. And outside of, so maybe we could expand this outside of traumatic brain injury, but in children specifically, picking up brain tumors that present with subtle symptoms of raised ICP or infections, or monitoring head injury or shunt malfunction. What's your experience, particularly I think relevant in third world countries, picking up children with subtle signs of raised ICP earlier? What is anything you use or you're comfortable with, or what's your experience? And maybe Adrian Chandrasekhar.
You mean clinically, for instance? There are some things, because we will all have patients who come to us who are seen at the emergency department, even by, we have this, it's like a cycle. We have residents who come from the adult program and they're looking at scans of kids who have shunts, and they would say, oh, this looks really normal. And you look at it and it's very subtle, or you look at the child, he has swollen eyelids, he has a puffy nose, the kid's not looking right. And, clinic goes a long way, knowing that ICP, it's not a linear phenomenon, that it comes and goes around the day and around the week, and patients who might have, I think every one of you has had a patient who has a completely blocked shunt, who was thrown up in the ED department and has, big vents. You go up, talk to anesthesians and tell them, listen, we need to, take this patient now. And when the patient comes in into the OR, the patient is sitting there and smiling, and then you operate on the kid, and the pressure is just like hitting the lamp, right? So it's the clinic is it's it's subtle, but I guess you have to take the time, like in anything else in clinical practice, to look at your patients and decide who needs to be treated. Of course, I know from your exploits that slowly ultrasound it's a great tool for knowing what's going on in there. And the other thing that we have been recently using, of course, not for patients who are in a very acute setting such as trauma, but I think one of the other things that's going to be very promising is OCT, for letting us know what is going on the optic nerve and the changes, especially, a patient who you did an ETV and you really want to know because the bends are exactly the same and you want to know whether the patient has actually improved or not. I think OCT is going to be a tool that it's not that expensive and that it's not that invasive, which might be promising. And I think that the coupling intracranial ultrasound and OCT perhaps is going to give us additional data. We need to work on this.
Okay, thank you, Adrian. And I think, Llewellyn, we can proceed with the second presentation.
Thanks, Mo. So it gives me great personal and professional pleasure and privilege to introduce our next speaker. So Dr. Chandrasekhar Deopujari is a renowned neurosurgeon from Mumbai, widely and internationally respected for his skill in endoscopic, minimally invasive surgery, pediatric surgery, epilepsy, and vascular disorders. Presently, he's professor and head of neurosurgery at the Bombay Hospital Institute of Medical Sciences in Mumbai, affiliated to the Maharashtra Health University, has a distinguished education ethic and reputation, as he's been invited on countless number of international teaching endeavors, both through the ISPN, the IFNE, and numerous national and continental neurosurgical societies in India and Southeast Asia. Of particular distinction amongst his many international publications in child's nervous system, pediatric neurosciences, minimally invasive neurosurgery, is he has previously served as president of the ISPN and numerous neurosurgical societies in India. He's also hosted a number of international meetings, including the IFNE in Mumbai, which was a really successful meeting, and hosted the ISPN meeting in Goa. So apart from all of these, he's one of the warmest people I've known and serves as a personal mentor to me in many ways. I've often bounced ideas off him before making important decisions. So it's a really a great privilege for me to introduce Dr. Deopujari to give us a talk on post-infectious hydrocephalus. So Chandra, if you want to.
Thanks, Llewellyn, for a kind introduction. I have put together some thoughts which have been expressed at various stages in our meetings, writings, etc. And I hope this is helpful for today's webinar. So basically, when we talk about post-infectious hydrocephalus, we are looking at one of a very common problem in the African as well as the Asian continent. There are several similarities, and I think this is one of them. And when we talk about post-infective hydrocephalus, we have to look at the pyogenic hydrocephalus separately, tubercular. Cysticercal is not so common, so I have not specifically looked at it separately, but that's the third one, which sometimes surprises you. When you look at the causative organisms, most of the Western Hemisphere, articles, books will give you, these are the various organisms, and they specifically mention that Mycobacterium tuberculosis is probably not a such a common cause, which seems to be a very, very common cause in older children and young adults in these countries. And as you will see that in the newborn, we find E. coli, Streptococcus pneumoniae are the common ones, while once you have crossed the infancy, you find tuberculosis prevails in all other age groups apart from the Streptococcus pneumoniae and meningitis. What we are looking at today is the post-pyogenic meningitis complications. Ventriculitis, subdural effusions, and hydrocephalus are the ones which either individually or collectively complicate acute meningitis or may manifest later as post-meningitis sequelae. And the most common reason is that in spite of a good kind of a response initially, you find that the symptoms remain persistent for a fairly long time with increased irritability and sometimes with signs of raised ICP, which also become manifest very early. And main reason why surgeons get called in is that though the milder variety are usually treated pharmacologically, many a times the hydrocephalus necessitates at least assessment by the surgeons, and many a times you have to probably look at various types of drainage procedures. Once you look at the hydrocephalus specifically, it can complicate acute meningitis or manifest later as the other complications as well. And most of the cases which we get referred are the ones which have been partially treated, either treatment discontinued early or patient has not been adequately treated. And the most common organism, as we saw in infants, is probably Streptococcus and E. coli, while in the elder group, the other one. When you look at the CT scan on these patients, you find that there is some muck which is seen in the ventricles, in the dependent spaces. If you give contrast, you find ependymal enhancement, and of course, either the subdural effusion or hydrocephalus or occasionally both. Treatment, of course, is prolonged antibiotics as per drug sensitivity, depends also on several organisms. Like most of the pyogenic meningitis, you need to treat at least for 6 weeks, most likely for about 3 months, while tubercular meningitis is treated much longer, current indication being about 9 months. Surgeries in pyogenic meningitis is usually by intermittent or continuous ventricular drainage, either for sampling or for release of intracranial pressure. And one of the treatments which is becoming popular, like the post-hemorrhagic hydrocephalus, is the endoscopic lavage. So this is a child, a 37 days old child with Pseudomonas meningitis, and you can see that you already start seeing some changes around the ventricles here, which are usually transependymal flow, but occasionally they may be inflammatory as well. And this child was managed with EVD and intraventricular colistin injections, which is becoming quite popular, of course, depending on the culture, but earlier gentamicin, we'll come to that in a minute. This is one of the papers in 2014 which talks about intraventricular antimicrobial therapy in post-neurosurgical gram-negative meningitis. And here they have studied almost 109 patients and shown that intraventricular therapy actually helped in almost the cure rate in these patients was 73.3%, which is much better than the average morbidity mortality associated with post-meningitic ventriculitis and post-meningitic hydrocephalus patients. On the other hand, there's another paper which talks about the fact that patients who have received intraventricular, this was specially studied with gentamicin, that the morbidity and mortality was worse in patients who required this. But this may also be because of the fact that many of these patients were sicker probably. And this is always a problem, that more sick the patient, more chances that they may get intraventricular antibiotics, and therefore assessing them with patients who did not receive becomes a little difficult. Endoscopic lavage is becoming more and more popular. Some of my colleagues have started doing it even in India now. Azmi, our friend in Malaysia, is very active in this kind of treatment. Basically here, if the infection is not clearing up and you see a lot of debris in the ventricles, either with a single or bilateral burr holes, you do a ventricular lavage. Most of the time, one lavage is enough, and many people sort of do irrigation afterwards, or sometimes you may require 2 or 3 attempts. And this has given good results in patients who have thick kind of ventricular debris. And it of course gives you a direct assessment of ventricles, immediate clearance, and minimizes future risk of infection. I do not know of any study if we have been able to reduce the number of shunt revisions, etc., like what is being claimed in post-hemorrhagic hydrocephalus. When we come to the more definitive treatment of hydrocephalus in form of CSF diversion procedures, one would like to delay the shunt as possible. Most of the times you would wait for the ventricular CSF at least 2 cultures to be negative before you would consider putting in a permanent shunt. And therefore, temporary measures like ventricular access device and subgaleal shunts are being used more and more frequently. And we'll talk about the antibiotic impregnated shunts in a while. Chatterjee has brought a very good kind of an observation to our notice, that in many of our children, especially the infants, where we think that the hydrocephalus is probably caused by aqueduct stenosis, you find that when you actually do a ventricular tap, which almost all of us do before putting in a shunt in any child, even with a tentative diagnosis of or definitive diagnosis of aqueduct stenosis, almost more than 50% of them were found to have some kind of an infection or increased protein, saying that probably there has been an infection at some stage. So ventricular CSF sampling has become an absolute must for us in all infants before we would consider putting in a shunt, even if there has been no definite history of infection. In terms of ventricular access device, I think one of the main reasons why they are becoming less and less popular, earlier in my first 15 years of practice, we used to use ventricular access device fairly commonly to withdraw CSF from time to time for sampling, and occasionally for instillation of antibiotic. But of course, the main reason it has not been very popular is because of the infection rate, which in best centers also is somewhere between 7 to 10%. The other mechanism which has become quite popular now is the ventricular subgaleal shunt. And way back in 2008, one of our colleagues from southern India had presented about 21 cases where they found that in 9 patients, this could be used as a sort of not only temporizing measures, but reduce the need for ventriculoperitoneal shunt while it was required in others, but they could be managed quite well. And these patients then can be treated even as an outpatient for maybe an occasional tap. Recent article by Sandeep and Kaushik, his colleague, also have written about their experience and found that ventricular subgaleal shunt is slowly becoming method of choice rather than keeping a ventricular access device for a longer time in most of these patients. Another study on subgaleal shunts done in Trivandrum by one of our colleagues has actually talked about 16 patients, all infants, where they found that it was much easier to manage them with subgaleal shunt rather than trying to put a ventricular access device or putting in an early ventriculoperitoneal shunt. One of the main reasons why the shunt insertion is delayed or one tries to avoid it is because stent malfunction is much higher in patients with post-meningitic hydrocephalus than in patients with other reasons. And you find a higher protein in CSF, which may be one of the reasons, the high cellular content in some of them, poor general condition of many of these patients, and because of these reasons, erosion of skin is also seen not too infrequently. Then when do we do ETV in pyogenic meningitis patients? Most of these patients have had some other cause as the primary pathology, like aqueduct stenosis or some obstructive lesion. And then if these patients develop infection, I would just show you one example. This is a 3-month-old child who came to me with a shunt infection. And we saw that this was an aqueduct stenosis patient. We removed the shunt. We treated this child with antibiotic with a couple of taps. And after 3 weeks, when the CSF was sterile, we went ahead and did a third ventriculostomy in this patient. You can see actually the effect of ventriculitis. You see pale choroid plexus. You see some kind of adhesions near the foramen of Monroe. Sometimes they are flimsy. Sometimes they are like a fluff, as you can see here. And luckily, we are seeing the basilar artery quite well here. But the main challenge is that the subependymal kind of nodules, you see them more frequently in tubercular meningitis, but you can see them even with chronic pyogenic meningitis. And once you see a clear space, of course, you go ahead and do this. One of the acid tests to see if this is going to work or not is actually how do you find the scarring in the prepontine space. For most of the patients with pyogenic meningitis, it is usually not so bad, unlike we'll see later what we find in the but you can see that there are some flimsy adhesions further down. Multiloculated hydrocephalus, actually, Levlin has done quite some work on this and has written about it, but it can complicate ventriculitis in many patients, and therefore many patients present with multiloculated kind of hydrocephalus. And here endoscopic fenestration of various septae, either using intraoperative ultrasound image guidance or using navigation, becomes a very, very important consideration in these complex cases. Very, very rarely you find that the pyogenic abscess may sometimes rupture into ventricle, like in this particular child, and the patient was treated for 6 weeks with antibiotics and eventually did not require a shunt. Review of literature showing mortality rates in patients with postbacterial meningitis hydrocephalus show you that the mortality rate ranges from 33% to almost 60% in best of the centers. Now we'll come to tubercular meningitis, which is a very big problem, not only in Africa, but also in South Asia. And we all know that this usually begins in lungs, and only 1 or 2% cases it progresses to TB meningitis. But even in a country like UK, you find 150 to 200 cases. In India, the number is in thousands. And hydrocephalus seems to be a more common complication of tuberculosis, reported in almost 85% of children, not so common in adults. Usually the disease is more than 6 weeks old by the time the children present with some kind of hydrocephalus. If you look at the historical perspective, the ventricular dilatation associated with tuberculous meningitis was written about by Hugh Keynes way back in 1951. Streptomycin was introduced then. And this is something which I learned from Graham, that Christian Bernard worked on tubercular meningitis way back in 1953 and found that internal hydrocephalus wasn't so common. This is before the CT scan days. Once we come to the CT scan days, one of the early papers from All India Institute by Dr. Tandon and his colleagues showed that in 60 cases of tubercular meningitis in adults and children, hydrocephalus was present in almost 87% of children, while only in 12% of adults. And therefore, we have learned way back in early 80s that it complicates childhood tubercular meningitis quite well. In fact, he felt at that time that the hydrocephalus probably dominates your thinking rather than the disease alone, and many a times shunts are put in without treating the tubercular meningitis adequately, either before or after the shunt, and that is one of the reasons why things don't work so well. If you look at the characteristics and outcomes of pediatric tubercular meningitis patients complicated with hydrocephalus, this is a paper from Indonesia, and again it shows that it is more common in younger children, and this seems to be a common finding in most of the developing countries. An epidemiological study by Dr. Murthy, one of our senior neurologists, gives us a good idea about the number of tuberculosis patients and CNS tuberculosis in India, and almost 31% patients he has shown across all ages. 31 patients out of 100 develop tubercular meningitis with hydrocephalus. HIV has increased that number for a while, and it has not remained as high today as it was 2 decades ago, but it is still fairly a common disease. Mode of spread, I think most of us already know that very rarely it is a rupture of tuberculoma in a vessel or contiguous spread of infection from adjacent bone. Most of the times it is a rupture of rich focus, which is cortical, subcortical kind of a lesion which develops in tubercular meningitis. Pathology wise, unlike the pyogenic meningitis, you usually get inflammatory exudates in the basal surface, and ependymitis and choroid plexitis is also fairly common. When you look at pathology of tubercular meningitis hydrocephalus, there are all mechanisms at work. Decreased absorption because of the blockage of the subarachnoid cisterns, then inflammatory cough at the tentorial hiatus, or occasionally even ventricular lining causing obstruction at various levels can cause obstructive hydrocephalus. And many a times, this is especially true in long-standing cases where inflammatory exudate extends to the ventricle, leading to choroid plexitis, and in the initial phase, it results into increased secretion of CSF in these kind of patients. Leptomeningeal scarring remains by far the most common cause, especially in later development of hydrocephalus patient. And we already talked about obstruction of somewhere in the ventricle or strangulation of brainstem by the exudates. In communicating hydrocephalus, you find that the earlier stage of the disease, you have thick gelatinous exudate in the subarachnoid space, while in later on, you get a fibrotic, you get a stage where there is overproduction of CSF, and then you get dense scarring of the subarachnoid spaces. And this is important to know because one of the main reasons why early CSF diversion procedures like third ventriculostomy do not work is that during the first and the second phase, you are more likely to fail. While during the dense scarring phase, if you can get a good opening in the base of third ventricle, later on your chances of CSF circulation are much better, and therefore your third ventriculostomy is more likely to work. It is also important to understand that it is also because the choroid plexus as well as the ependymal lining with inflammation, they do not remain very active in terms of absorption of fluid. So over a period of time, the CSF absorption capacity keeps on getting less and less in these patients. And this is also one of the reasons why in many cases that in spite of early control of tubercular meningitis, you may still continue to have a patient who suffers from CSF obstruction or CSF circulation disturbance. So basically, the ependymal cells which line the ventricle, they can their cilia get affected, and that is one other reason why we have this problem about more chances of developing hydrocephalus compared to the pyogenic meningitis patients. Imaging wise, you look at tuberculomas, you basically look at basal exudates and early hydrocephalus as the signs for tubercular meningitis with hydrocephalus. And then you would categorize it as mild, moderate, and severe. If it is mild, you will consider medical treatment with maybe a few lumbar punctures, while if you see very thick exudates and large ventricles with periventricular ooze, you will probably consider an earlier shunt. Increased ventricular size, as I said, usually is seen beyond 6 weeks, but very rarely it can be seen acutely. And subependymal seepage, of course, occurs commonly. Some of it may be due to inflammatory changes, but most of it, at least in the beginning, is due to the periventricular ooze. One of the hallmarks of tubercular meningitis hydrocephalus is you usually see some infarcts in the basal ganglia area or the deep structures. You can see the infarcts here in basal ganglia, and you can see multiple tuberculomas in the basal subarachnoid spaces in some cases. And very, very rarely you see a tubercular abscess which actually contain bacilli. Cine MRI becomes important to categorize the hydrocephalus, and this is important if you are considering an ETV. We will usually check it with Cine MRI, and this can be easily done if there is a facility of 1.5 Tesla or higher Tesla MRI, and this has almost taken away the need for doing a pneumoencephalogram, which was described by the Cape Town group much earlier to differentiate between the two, where they have shown that you can easily diagnose a communicating hydrocephalus versus non-communicating by just injecting air in the lumbar puncture. So signs of raised ICP may be subtle. The CSF picture usually shows lymphocyte prominent pleocytosis in lumbar CSF. Most of the time, this ventricular CSF remains normal. There is a definite kind of consideration that the disease is probably appears late following spread of primary complex in children, while it may be reactivation of or widely disseminated active disease in adults. Presentation is usually acutely ill patient in children, while it is a chronic kind of a disease in adults. Hydrocephalus is, of course, more frequent, occurs earlier and more severe, while it is late and subtle in adults. And impact of HIV has had minimal impact in children, while it has had a massive impact in adults for obvious reasons. Now, to stratify the tubercular meningitis hydrocephalus, there are several gradings which have been proposed. The most important grading which is used to stage the disease and assess outcomes is the Valor grading, which was described in 1998 by Rajshekhar and his colleagues. Medical management is obviously necessary. Antituberculous therapy, steroids form a very important component of the treatment because they do not allow dense scarring if it is given from the early stage of the disease till for a fairly long time. The PGI Chandigarh paper has actually recommended that a minimum 90 days of steroids should be given, which can probably help you to reduce the incidence of hydrocephalus, but I have not seen any other paper talking about that. Acetazolamide is used by most physicians to reduce CSF production, though I'm quite skeptical about it, and we do not have good papers to support that. And dehydrating agents such as mannitol, diuretics, etc., are given only as a very kind of transient measure till we decide on a definitive management for CSF diversion. Pharmacotherapy is extremely important and is the first line of treatment for communicating hydrocephalus. The standard 3 and 4 drug regimes, I think, are very well known, are written here for pediatric patients. This is the common protocol which is being followed in most of the developing world. And steroids, as I told you, for a minimum of 4 to 6 weeks. And if you see that the hydrocephalus or infarcts are developing, it is usually given up to 3 months. Now, MRC stage 3 tubercular meningitis with high degree of basal enhancements are probably the highest prognostic markers for development of hydrocephalus. Intrathecal therapy has been tried by a group in South India, and also several years ago, Dr. Bhagwati, my mentor, actually carried out in our own department, and we found that it probably works in about grade 3 disease, but in grade 4 and 5, it did not have any favorable outcomes, and grade 1 and 2 do not really require it. So maybe in some cases, it may be of use, but it has not become a standard of care because of development of certain problems, local problems, and possibility of developing arachnoiditis. Surgical management, of course, VP shunt remains the most common procedure performed, and endoscopic third ventriculostomy, we will talk about its consideration. Ventricular atrial shunts were actually the initial choice of shunt procedure in previous years. And as I was telling you, Dr. Bhagwati, my mentor, actually described it. They have produced the first paper on VA shunts in tubercular meningitis way back in 1971. And the Vellore group also followed, and it became the standard of care for about 12 to 13 years before ventriculoperitoneal shunt became common. I think it started in the South Africa, as you can see from these references. And then it was talked about the fact that shunts are not perfect devices, and therefore wherein to put the shunt, in which patients to put the shunt, and where you should either delay or avoid a shunt. Those kind of studies started in 90s. And one of the most important publication, as I told you, by the Vellore group showed us that from grade 1 to 3, probably the shunts worked, and therefore they talked about trial of EVD. In grade 4 and 5, if the patient improves, then only you go for a shunt. And the other reason, of course, is the high rate of complications. The earliest one described is about 32% complications. And I think the Cape Town group is probably responsible for resurgence of third ventriculostomy, which had initially become unpopular. And then Dr. Mazhar Hussain and some of our colleagues in India started in earnest and showed some reasonably good results. So indication for CSF diversion procedure on a permanent basis, either endoscopic third ventriculostomy or shunt, are grade 1 and 2 communicating hydrocephalus, especially for shunts. Fair side of deterioration in patient's consciousness, radiological evidence of progressive enlargement of ventricles, and occasionally CSF manometry, which is usually not performed in this patient. And if there is obstructive pattern of hydrocephalus, then you would probably consider an earlier shunt than later, or a third ventriculostomy, of course. Ventricular tap can be done either with a twist drill or the standard way of putting external ventricular drain or an access device. And this is the paper I was talking about, which came out with a very good result. And one of the things which this paper showed is probably that the response to meningitis also improves after drainage of CSF, because the blood-brain barrier probably becomes more efficacious. That was the kind of theory put forward at that time. And Dr. Rajshekhar has summarized it quite well, and I think it is still valid that surgery for patients in grade 4 is usually associated with poor outcome, and therefore these patients should be tried out with ventricular drainage or probably temporized with either a ventricular access device or subgaleal shunt before you consider shunt as a definitive kind of a procedure in these patients. These are the kind of patients who are not likely to do very well. So this is a disseminated kind of tuberculosis. Patient has basal exudates plus tuberculomas. This patient later on the tuberculomas have cleared up, but the ventricles have started ballooning up. By this time, patient is about finished her anti-tuberculous therapy. CSF is almost normal. And at this stage, she has had a shunt put in. And fortunately, this girl has recovered quite well, more than 16 years follow-up now. Higher incidence of shunt revision was showed at AIMS, was another center in Calcutta and Lucknow, where they have shown that there is a higher incidence of shunt revision in tubercular meningitis patient and other shunt malfunctions, including shunt infection, erosion of the skin, etc., and especially in poor nutritious patient. And the data from, I think this is a paper from PGI Chandigarh, I think, where they have shown that the worst prognosis in TBM patients may be due to primary disease than the functioning of the shunt, and therefore shunt still remained the mainstay except for patients who were otherwise good candidates for third ventriculostomy. So this is a patient with resolving basal exudates, a fourth ventricular enlargement here, trapped fourth ventricle, and these kind of patients require fourth ventricular shunting because of the infective pathology. We have not tried any kind of internal stenting or third ventriculostomy in these patients. This is another patient who has a trapped temporal horn. Rest of the ventricles have drained well. This had to be drained separately by another shunt. Endoscopic interventions have become very popular after, as I was telling you, the Cape Town group and Dr. Hussain from Lucknow in India, they showed over 50% success rate. And then there was further analysis of in which patients we should be using it. And success of ETV mainly depends on thickness of the third ventricular floor, favorable cisternal anatomy around the third ventricle, and the most common complications of ETV are failure because of the anatomical distortion and CSF leak. So if you are able to perform a third ventriculostomy and see the prepontine space quite clearly, then probably you have a good chance of success. As we were just talking, you get this kind of subependymal nodules, and the aqueduct is narrowed here, and the third ventricular floor is thickened. And in these kind of patients, you actually get exudate here. In spite of making a good opening, you may still not be able to do it. This is another patient who has been treated quite well earlier with a shunt, and the shunt got blocked. These are the ideal patients where what we call secondary third ventriculostomy works well. And here, as the disease has burnt out, the floor has become quite transparent, and you could do a third ventriculostomy quite well in this kind of a patient, and it has helped the patient quite well. We wrote about this out of our 40 children. I think almost 20 children were post-infective meningitis hydrocephalus patient, and therefore in TBM with hydrocephalus today, I think in grade 1, grade 2, and grade 3 patients, you would go ahead with either a shunt or a third ventriculostomy, depending on at what stage you have to do it. Within the first 2 months, I am not in favor of going for a third ventriculostomy. Beyond first 8 weeks, if the patient develops hydrocephalus, which is of obstructive type, then you have better than 60% chances of success. This is what our findings have told us. This is a child where she developed acute hydrocephalus early in her disease. Within first 6 weeks or so, came back with large ventricles. We put in a shunt here. And when the shunt got blocked at a later date, we decided to go ahead with a third ventriculostomy. You can see that the floor is opalescent, and but you can see the basilar artery quite well. And though you do not see much beyond, it seems fairly safe to do this. So we opened this up, and fortunately the prepontine space looks quite clean. You can do directly with the scope in blunt scopes like the Minop or some of the new scopes. And we check that up after 6 weeks to 3 months with a cinecysternography, if the stoma is working well or not. And these are the various series which have given a percentage from, again, 0%. This was Chatterjee's paper of only 4 patients, but most of the other people have shown somewhere between 30 to 80% in post-meningitic hydrocephalus for a third ventriculostomy. Other important thing is that isolated ventricles can be checked quite well. Like this patient had foramen of Monro functional block, and septostomy cleared that. So there are other advantages of endoscopy. And lastly, I would show you that in multiloculated hydrocephalus, we did this ultrasound and navigation guided opening into the cyst. And then actually we also got help to do a third. This is the opening into the cyst. And then we did a third ventriculostomy after doing the septostomy. And after doing this, when we are dilating this, we observe that the prepontine space, you can see the thick floor, and there are a lot of membranes in the prepontine space. So this patient at this stage, actually, we came out with doing a subgaleal shunt. And after about 6 weeks, when the CSF became completely normal, we went ahead and inserted a ventriculoperitoneal shunt. So you have to use different strategies to treat these patients effectively. And though the initial scans looked well, as I told you, that the patient did require a shunting later on. Poor surgical outcome can be due to encephalitis, various infarcts if the patient has suffered earlier, which are the main predeterminants of poor outcome in these patients. Another fact which has come to the notice is that though initially they might seem to have grown well, if you look at their average performance and developmental outcome, you find that they are probably not so well with their peers. So there is, in many of these patients, though we have been able to reduce the mortality and probably able to reduce the need for shunts, we still have patients who would probably have some kind of a subnormal development. And we've written up about this in Dr. Chinali and Diroco's book recently. So thank you for a patient hearing. Happy to take any questions.
Thanks, Chandrasekhar. That was really a spectacular overview, and I think the experience you have in this field speaks for itself. I'm going to open. I'm just looking for some questions. I don't see any particularly relating to this, so maybe I'll open it up for comments. Maybe Moody, you want to start off? Any comments?
I think Chandrasekhar has left no room for any additional comments. It's such a masterclass of a superb overview. He's covered a huge ground. I think the dilemmas he's described are well known to all of us, and we always struggle to get the child with either post-infectious or post-meningitic hydrocephalus treated. But Chandrasekhar has shown us all the tricks in the trade to get across that. The only question that keeps cropping in my mind, especially after this vaccination debate from the COVID period, is a lot of our children are obviously, the neonates, the young babies, are post-infectious. And one wonders whether there is a role for molecular profiling of the CSFs to find out whether there's a common regional bacterium that affects the children in a particular group, and then to develop a vaccine for that region, so that all children in that particular county or region get a particular vaccine, and whether that will reduce the rates of infection that we see. We see a lot of post-infectious hydrocephalus, and really we can keep shunting them. We can do ETVs. We'll never have enough neurosurgeons to do all the ETVs that we and the shunts that we need. And I'm just wondering whether, from a preventive point of view, that's a line that we should perhaps begin to pursue, certainly in the countries that we work in, where there's a lot of post-infectious hydrocephalus. I'd be interested to hear your thoughts, Niluel and Chandrasekhar, what your thoughts are. Because if we can get some kind of vaccine developed for these children, I suspect their rates of meningitis and post-infectious hydrocephalus will perhaps drop. I'm just, again, thinking aloud, but it's been a question on my mind for ever so long. What are your thoughts?
Basically, Moody, I think pneumococcal vaccine has now become, a standard of care. And I think most of the children, at least in India, it has become part of the, vaccine schedule for all small children. BCG vaccination is usually not given so early. I'm not sure at what age it is prescribed, but I think it is not prescribed so early in life. So I actually, you have brought up something which I have really not studied well. So if it can be given early, it has not only been found to be effective in terms of, altering the course of the disease, if not preventing it. It has probably also helped us in COVID. That was the, kind of a suggestion given early for some of the developing world not getting so badly affected, where BCG vaccination is very prevalent. So I don't know if the BCG vaccination age should be advanced, because we really don't know of many strains which are different. I think there has been enough work by ICMR in India, and the germs are no different from what I have understood. I don't know about the Africa scene.
And that's where the concern is. It's not all the CSF that we've grown, cultured. Not all of them are of a particular strain, and one just wonders whether there is a regional difference, and if there is, then a focus on that side for prevention may be one of the strategies that we should try to promote, and perhaps a collaborative study on doing just that on some of our countries may be a way forward, because we really get frustrated because A, there's too many, two, the cost of shunting, and even though and I was going to ask you obviously by and large would use the Chabra shunt in your situations, or
it is
getting we entirely rely on the Chabra shunt here.
As the whole country is changing a little bit, there is more and more demand to use
the more expensive
shunts, more expensive shunts, and especially in these kind of patients or patients who have definitely had CSF infection earlier. Not only neonates. I have used antibiotic impregnated shunts for about 3 years. Now they have been discontinued again. So we'll have to wait and see. Currently, we are using Chabra or Pudens shunt in most of these patients, depending on the availability in the hospital at that time.
Yeah.
Regarding TB, I'd like to make a comment.
Yes, Andrew.
I'm driving, but I'll tell you a little bit. As told you, it's a very small country, right? We have a universal healthcare system, so everybody has access to it. And especially when you have, universal access, you can get some interesting data when it's such a closed population, such as ours. That was like the success for the folate fortification program. And let me tell you that all kids here get the BCG vaccine upon birth, every single kid in the country. So we literally do not see any sort of tuberculosis-related meningitis. We just don't see it. Every single time Chandra can witness that we just do not have that kind of experience. So
Yes.
I think that's one of the cornerstones of massive vaccination of all kids upon birth.
At what age is it given, Adrian?
I think it's given within the 3 first months of life. And we just don't see it.
That's very interesting. I think that's the kind of approach that one needs to perhaps promote. That's a very. It'd be interesting to see any papers from your region in Costa Rica, because really your mind keeps focusing on prevention because of the numbers.
That's right. I think being a welfare state, Adrian's country has really made very good progress in basic health care. You have any thoughts, Levlin, about vaccination at all?
Sure. I'll make some thoughts. I'll mention a few. Just quickly, I see there's a Dr. Abdallah who's had his hand up for a while.
Yes.
Yeah. Do you want to ask a question, Dr. Abdallah?
Abdullah is asking about use of third ventriculostomy in children less than 1 year with post-meningitic hydrocephalus. I think I have used it, but as I told you, most of these are when the shunt has failed. There are very few patients where the disease has cleared up early, or the patient has virtually stopped or nearly stopped tubercular meningitis toward the end of their medical treatment. At that stage, if some patients developed hydrocephalus, I would consider it. Otherwise, I am not considering it as a primary treatment in post-meningitic hydrocephalus.
And what is the percentage of success of these ETVs usually?
In our experience, we have had about 20 odd patients with post-meningitic hydrocephalus in that secondary third ventriculostomy group. The success rate in them was about 70%.
Well, this is not what we was taught about the endovascular. I mean the third ventricular cystinostomy, because what we do in the third ventricular cystinostomy is just to make a bypass from an obstructed area to an area which can pass the CSF to the subarachnoid spaces to be absorbed there. And if we have the subarachnoid spaces already maneuvered or not functioning due to the meningitis, either from TB or from other type of meningitis, I don't know how that ETV can work still. I can imagine maybe it can reduce the hydrocephalus intraventricularly, but it will cause bilateral hygromas, or what we call external hydrocephalus. What do you think about that?
Certainly not in the active phase of the disease. I would say that only if you think you have been able to control the disease only in the later part of the disease. And as I have told you, the most success rate we have had in patients who have actually presented to us with active hydrocephalus with shunt failures. Because I think once the disease has burnt out, the subarachnoid spaces also open up. In the late phase of the disease, the challenge is really to see a good anatomy to make an opening. Subarachnoid spaces have usually opened up by that time, not in the early part of the disease.
Do you have statistics about that? I mean, how many cases you did, how many cases which was really worked properly and didn't develop hygromas or external hydrocephalus instead? And what about ICP measuring? I mean, was it
We do not routinely
was it
measure
recorded?
ICP, but as I told you, when we have put in late stage of the disease, we have had some 28 cases done, and I think 20 have worked well. It is I'll have to take out that paper data from that paper, but that is what we have seen when we last looked at it in 2018. About
Well, anyway,
70%.
if it is the case, it's worth trying it really properly. And I mean, that's really encouraging. Thank you very much. Hello?
Okay, thank you,
Thank
Dr.
you.
Abdullah.
Thank you.
There is another question, Chandra, on the board. Is there any ventricular size changes in children after infected by SARS-CoV virus COVID-19? I don't think we have an answer yet for this.
To tell you frankly, I have not seen a child with hydrocephalus following COVID-19. Fortunately, symptomatic COVID with any kind of CNS manifestation has been extremely rare. Offhand, I remember only one patient who had some kind of a, I think, encephalitic illness, but no hydrocephalus. I have seen in adults patients who have had some bleeding and ventricular enlargement, but the primary reason for that was they have had subarachnoid hemorrhage. I have seen 2 patients like this in about 20s, that kind of age group.
Okay. There is another thing which I would like to ask you about, the entrapped forced ventricle shunt. When you put this shunt, do you put it a medium pressure or a low pressure shunt? Because this is an entrapped forced ventricle, which is supposed to be with a low pressure, not with, I don't know, but I usually use a low pressure in when tapping the forced ventricle, especially.
I have also used if you have seen in that patient, the lateral ventricles were drained well. So there was no scope of doing, stenting of aqueduct. And I have now 4 or 5 patients like this who have required direct shunting into the fourth ventricle, and I use a low pressure shunt for that.
Okay. And what do you think about the ventricular lavage? Have you tried the lavage of the ventricle?
I have personally not tried, but one of my younger colleagues is trying it out for post-hemorrhagic he's taken it up as a, we should have some data to tell you in about 6 months or so.
Okay, thank you. So any comments more, Llewellyn?
No, look, just some comments on the endoscopic lavage. I think like Chandrasekhar said, it seems promising, particularly the data supported in intraventricular hemorrhage, but we've tried it a few times in kids with pus in the ventricles, and some varied results. We don't have a huge experience with that, but I think, like Chandrasekhar pointed out, I think probably Azmi Ali still has the largest experience with that. I know he's certainly been talking about it for a long time now, and he's quite a strong advocate of doing that. Says it decreases the incidence of multiloculated hydrocephalus and shunt dependencies. It certainly seems, if done in a very standardized way, it has some sort of promise.
Have anyone tried intraventricular antifungal in case of fungal infections? And what type?
No, I've never done that.
Any experience?
No.
Chandra, do you have you tried the?
We have recently had actually 2 children with fungal infection, but we have not tried intraventricular fungicide treatment. They have received intravenous treatment. And in later part of the treatment, after first 6 weeks, they have received oral treatment.
So the antibiotics inserted in the ventricle are vancomycin, amikacin, colistin, and there is one antifungal, which I have read a paper, I don't remember the name, but I was pushed once by the oncologist to put intrathecal.
Amphotericin must be amphotericin.
Amphotericin, yeah. But I didn't accept actually because it was just one paper and I was afraid of injecting it.
I have not used it. The common antibiotic which we put in today is either amikacin or colistin.
Yeah.
Vancomycin, colistin. Moody, you have a
Vancomycin is supposed to have
Yeah.
quite a severe ependymal reaction. So I would like to know. Our bacteriologist doesn't want us to use it.
We put a very low dose. We dilute 500 mg in adults, 500 ml milligram vial in 500 cc. So it's basically 1 milligram per cc. So you remove 5 cc's and you replace it with 5 milligrams. Well, that's what we've been using, and we have not had an issue with that. But obviously, we don't have a study big enough to to indicate that. But that's the kind of dosage we use.
We use it regularly, actually. The vancomycin intrathecally in
What sort of
children, we
dosage?
didn't have problem. It's a 1 milli. One milli, yeah. And also, what I have seen is what the colistin. That's severe reactions usually happens when using the colistin for a long time. But with the vancomycin, I haven't seen that.
Yeah, we haven't seen that. But again, we haven't done a endoscopic evaluation after that. We don't know.
Yeah.
But but we've found that we've managed to get over the infection.
Yes, sure.
Reasonably, yeah.
And what about having a high protein level when you are having infection? Sometimes the shunts are not working. Have you tried injecting intraventricular DEXA, which reduce some of these high protein levels before inserting the shunt when changing from external drain to a shunt?
Or I have not.
Frankly, till about 500 milligrams, I do not worry about it. If it is anything more than 500 milligrams, then you have to tell the patient or the family that chances of shunt failure are higher. But we are not using any medication.
In those situations, would you use a ventricular access device, Chandrasekhar? In those situations?
Surgiware has something like a Omaha reservoir. That's what we usually do.
Until the CSF becomes less than 500. Because we see CSFs at about nearly a gram, and that's almost guaranteed to get blocked.
Yeah. You can try also putting, I think, a low pressure shunt in the ventriculoatrial when the protein is high. This works instead of ventriculoperitoneal.
It's a good suggestion.
Okay.
And what's the mechanism? What's the thinking that that it doesn't get blocked? Is it because there's a pumping action to it, or?
It just we had the ventriculoperitoneal shunts inserted and they plugged. We changed it to a ventriculoatrial at a low pressure, and it was working. I don't know actually the mechanism, but most of them when we change them to a low pressure.
I think pressure gradient is higher probably, and it's a shorter tube, so maybe the chances are less.
But the other thing is that if you remove the slits and just leave it open, and then it converts into a low pressure shunt, then it's less. It's the slits that get clogged up. But if the opening is patent, you've removed the slits, it converts into a low pressure shunt, and again, being shorter, less likely to get blocked. Is that your thinking, Mohammed?
Yeah, I mean, when we use a low pressure shunt, it's when in the ventriculoatrial, I don't remove the slits because it easily get blocked with a thrombus. But the slits on both sides work well when in the ventriculoatrial. In the peritoneum, yes, we remove the slits, but we simply change the reservoir from medium pressure to low pressure, and leave the slits in the atrium, but remove it in the peritoneum.
That's interesting.
Yeah.
No. We always learn something on these webinars. Really.
Yeah.
Great.
Okay, Llewellyn, you have
Yeah.
any more?
No,
Can
no,
wrap up?
I think that was really great. Thanks so much to both our speakers, Adrian Kachiras, who took specific time out amid some family crises. So Adrian, thanks so much for making it enough of a priority to attend. And Chandrasekhar, it's been a while, and it's always a massive, massive pleasure to catch up and listen to your tremendous experience in this and so many other facets of pediatric and neurosurgery broadly. Moody, as always, thanks so much for your time, effort, and support. And Mo, you know, we keep on doing these things. We'll check with John. I'm not sure if you want to do one in December or whether we take a bit of a holiday break in December and catch up from Jan, but we'll let you know. And then John Bennett, again, thanks so much, John, for all your effort and work. Always appreciated. Okay, thanks, Mo. That's all for me. If there's anything you want to add.
Thanks, Llewellyn, Mohammed, and John.
Thank you, Chandra. Thanks, Moody and John. Thank you.
Okay, thanks everyone for participating, and thank you,
Go to
Llewellyn
sleep
and
now.
Mohammed.
For Chandra, it's past midnight now, right? Chandra?
Absolutely, absolutely.
Yeah.
Okay, thank you,
He's
everybody.
already gone. He's already in
Need
Wednesday.
to go to OR soon.
All the best. Good seeing you all.
Good
Yeah,
night,
good
guys.
seeing you.
Good night.
Thanks.
Good night.